Many factors can influence healthy aging. While some of these factors, such as genetics, are not within our control, research shows that there are steps you can take to help manage your health. Fit for Life, Improving Men's Health. Tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Andrew Ellsworth, and tonight we are discussing issues surrounding men's health and well-being. Prioritizing men's health and staying healthy through yearly exams is crucial in preventing serious health conditions and detecting potential issues early on. Regular checkups can help men monitor their overall health and catch any medical problems before they become more serious or difficult to treat. By staying proactive with their health, men can reduce their risk of developing chronic diseases such as heart disease, diabetes, and certain cancers. Tonight, we will discuss men's health issues and take viewers' questions. Thank you for joining for our discussion. This evening, we are joined in the studio by Dr. J. Spencer Edman from Urology Specialist in Sioux Falls and Dr. Daniel Reiffenberger from Prairie Lake Brown Clinic in Watertown. Welcome, and thank you so much both for joining us tonight.
Yeah, thank you for having us.
Dr. Reiffenberger, if you don't mind telling us a little bit about yourself.
Well, I am a family physician, and my wife and I are both family physicians. We've been in practice for 30 years, all of them in Watertown. I now took on a new role here in the last year. I'm also the CMO at Prairie Lakes as well, and then practice part-time.
Chief Medical Officer.
Chief Medical Officer, yes.
Excellent. And you're from Watertown originally?
Correct. Born there and then grew up in Sioux Falls, then came back.
Excellent.
So,
thanks for being on the show. You've been on the show a couple times now.
Yep, I think this is 5 or 6 now.
Wonderful, wonderful. Great to have you back.
Thanks.
And Dr. Edman, tell us about yourself.
Hey, Spencer Edman. I worked down at Urology Specialist down in Sioux Falls, and so I grew up in Sioux Falls and went to high school there. Went out to Indiana for undergrad, back to South Dakota for medical school, down to Iowa for residency, and now back to South Dakota to practice. And so happy to be back in South Dakota, back where I was born and raised. Something always just kept bringing me back here, but appreciate you having me on, and excited to talk about some men's health stuff.
Excellent. Well, I'm from Madison myself originally, now in Brookings, so we've got 3 South Dakota boys here.
Once South Dakota, always South Dakota.
Something always drew me back.
You got it. Well, before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion regarding men's health issues. Viewers can contact us 3 ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous, and no information is saved. Viewers can, however, leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. So this is a men's health show, and we've got a urologist, we've got a family doc. We're kind of just the spectrum of men's health, and we're happy to answer any questions about men's health. We don't want to scare away our women viewers. And we all know that actually it's the wives and the daughters that mainly take care of the men in their life anyway.
They're the reason men come into the office.
Exactly. So we appreciate that they'll be watching the show and trying to get their man to follow through on maybe some of the things we're talking about.
Right.
Exactly.
So Dan, when we start, if you've got a guy that comes in for a physical, why should he come in for a physical, and what are some of the things you're going to be looking through to help him?
Well, and again, regardless of age, we're all going to cover certain things. Do you have any concerns, issues, problems? Okay, prevention is going to be a key. That's what family medicine is about. Okay, so it comes to immunization, screening, colonoscopy, lab work, diabetes screening, PSA screening for prostate cancer, all of those. And each age or category may have some different things that we may cover in there, but then the exam is also the other crucial part with it besides anything, the history. But the biggest thing first is there anything that you're worried about or concerned about that brought you in today?
Yeah, and go from there.
And go from there.
What does a urologist do, Spencer?
Yeah, so urology, so we work on the surgery of the genitourinary system in general. So working on kidneys, ureters, bladders, prostates, urethras, penises, testicles, and we deal with kind of anything around that system. And so do surgery on those things. We work on medical therapy for those things, and then do smaller procedures kind of in between as well. And so a nice various field, but mainly taking care of men and men's health, although maybe about 20 to 30% of our patients are women with regards to kidney cancer, bladder cancer, and kidney stone stuff.
One of the things I think of that's extremely common for men is having to get up at night to go to the bathroom a bunch.
Yeah.
What could be going on there?
Yeah, that's a great question. And I think that it's an interesting question because there's a difference between nighttime causes of frequency and daytime causes of frequency. And by frequency, I just mean using the restroom more frequently. So when we're talking about nocturia, or kind of the frequency at night, we're talking about waking up at night to use the restroom. We're not talking about waking up at night, laying staring at the ceiling for a while, saying, I guess I'll go use the restroom, and then going back to bed staring at the ceiling for a little bit. This isn't sleep issues. This is, I wake up and I have to use the restroom. So the first thing that I do is I figure out, hey, how many times are we using the restroom at night? And then I start to ask 3 specific things, because I think there's 3 things to me that are really strongly associated with nocturia, or going to the bathroom more frequently at night. The first thing that I talk about is sleep apnea. Sleep apnea is really important. It's not only important for high blood pressure and other parts of health, as I'm sure we could learn, but it's also important for nocturia. The way I describe it to folks is, hey, when you're not breathing at night, your body's getting less oxygen. When you're not getting as much oxygen, your blood pressure increases. When your blood pressure increases, your kidneys filter urine more frequently. And we actually did a study as a urology field, and found that people that have obstructive sleep apnea end up making about 2/3 of their urine at night versus about 1/3 of their urine during the day. And I tell people, hey, if this is a production problem and you're just making more urine at night, I can't fix that. I'm not a guy that can decrease the amount of urine you make. I can help you get rid of it more effectively, but I can't necessarily decrease the amount of urine you make. And so talking about getting treated for sleep apnea, sending them to their family practice doctor to get evaluated is the first thing I do. Second thing I do is I talk to them about when they stop drinking at night. Hey, when is the last thing that you have to drink before bed? And the classic is, guy comes in, he says, I pee 6 times a night. I say, when do you stop drinking? He's like, well, usually drink 64 ounces of water, in a couple hours before bed. And I say, well, it makes sense that you're getting up and you're peeing all night because your body's trying to get rid of that fluid. So we talk about stopping eating or drinking, about we'll say an hour or 2 after dinner, or 3 hours before bed. Last thing that we talk about is lower leg swelling. I always ask my folks if they've got lower leg swelling. They always tell me no. I then go look at their sock line, and sure enough, they've got a little edema on their legs. And I always ask them, hey, I want you to kick your legs up before the end of the evening. I kind of describe it as, hey, each leg is like a glass of water, and when you kick it up, it's like drinking 2 glasses of water. And if you do that when you're in bed, hey, that's 2 glasses of water you're drinking in bed. Versus if you're doing it 3 hours before while you're sitting in the lazy boy, it's a good excuse to get in the lazy boy too. But if you do it 3 hours before, you get rid of that and you diurese that earlier, and that allows you to hopefully make less urine at night. And so once we've taken care of those conservative things, then we can really start to get into the voiding dysfunction stuff, and that's where we start to talk about, hey, that's where the things parallel between the daytime symptoms and the nighttime symptoms. Are we not emptying our bladder as well? And do we have an overactive bladder? Do we have a small bladder capacity? All these things can kind of play in as well, but when we're talking about nocturia, oftentimes it's those first 3 things I talked about: sleep apnea, lower leg swelling, and then when we stop drinking at night, that really makes an effect on nocturia.
And absolutely, those are some great things to look into first. And of course, you're running into this problem all the time too, Dan.
Every day.
How do you often approach that then?
Same type of thing. Again, it's coming down to history. They're going to tell you the story as far as what's going on. Okay, as far as sleep apnea, are you having headaches? Is there blood pressure up? Do you snore? Has your spouse ever said, I'm ready to hit them with the elbow because they quit breathing, as far as with it from there? Is there sleep apnea on their side of the family? So all of those factors come in. Does it hurt when they go to the bathroom? Have they been more thirsty? Want to make sure diabetes is not part of the factor as far as with it, to rule that part out, or they're not having anything of an infection, whether bladder, prostate, anything as far as with it. I'll say too, from the edema, okay, what do you do all day? Are you sitting majority of the day and your legs are bent? How is it in the morning when you get up? Flat again, doing fine? Okay, I'm not as worried as far as with it from there. Some, if they're on their feet a lot and it's called dependent edema, sometimes we need to wear some compression stockings. I will do that now. I'm sitting and squatting as far as with my legs bent as far as with it, and then I'll have a bigger sock line at the end of the day too. And like I say, you're going through that history and questions as far as with it, trying to figure out, okay, what other issues or concerns are they having? You have to look at their medications too. Some of the times medications they may be on for something may have side effects in relationship to those things too. So that's a start.
You know, and so now if we've kind of ruled out or looked into a lot of different causes, of course, one of the most common causes for men as they get older is the prostate gets bigger. And so what is happening there, and what can you do to help?
Well, every year as we get older as a male, our prostate is going to get bigger, okay? When we check that blood test as for screening of prostate cancer, okay, it's called a PSA. That number can go up from a prostate infection, and go up from the gland getting bigger because it's producing more. Okay, and correct me if I'm wrong, but I was always taught the PSA wasn't ever originally to be used as a screening. It was used, somebody had prostate cancer, and it was used as a marker to determine treatment. Yeah. As far as with it. So it's kind of shifted into that, and it's not as accurate as being able to tell for sure whether prostate cancer is with it. If it's elevated, you have to make sure prostate cancer is not the issue. So that's where you come into play, because 4 is the threshold, and a PSA 60s, 70s might be 6 to 6.5, but 4 is still my threshold. If they hit that, depending on where it is, may repeat it again in 3 to 4 months. If it's there again or higher, then I'm referring them to you.
And that's exactly how you should do it. Always be rechecking our PSAs. People come in, they get one elevated PSA from their family practice doctor. Their family practice doctor says, hey, I want you to go talk with the urologist, rule out prostate cancer. Patients hear prostate cancer, and they come in and they think they have prostate cancer. And I tell them, hey, the first thing we need to do is we need to get another lab value to check this. PSA's half-life is about 6 days or so. It takes a little bit of time before that PSA really kind of cycles out. And so if there's an event like an infection or inflammation or trauma to the prostate, those things can transiently increase that PSA. And hey, 6 weeks later, all that's washed out, and not all these patients, but a good amount of these patients end up PSA normal. And hey, they got really worried about absolutely nothing. Yeah. And so first thing is to always recheck.
But for first, I think I'm asking more about, we'll get to prostate cancer for sure, but asking more about an enlarged prostate causing someone to urinate frequently at night. And so let's say that they've been having their PSAs and they're staying low. Mm-hmm. It's going to naturally increase as well as we get older too. But what can we do about that?
Yeah, so I look at PSA in that sense as a predictor of how big I think the patient's prostate is. In the sense of, hey, if their PSA is down by 1 or 2, they probably are on the smaller side for a prostate. If it's towards 4 or 5, hey, they're probably on the bigger side for a prostate if this is a consistent value over time. So that gives me an idea, hey, are we more dealing with a guy with a small prostate that has overactive bladder symptoms or pelvic floor dysfunction, or am I more dealing with a guy that's got a really big prostate and that's really kind of obstructing things? I always describe it to my patients as the bladder is a big muscle. The prostate is trying to prevent the bladder from getting urine out. As the prostate gets bigger, it grows and it narrows that kind of hole that we're peeing out of, makes it so we're peeing out of a coffee straw. The bladder has to get bigger and stronger as a result of that. Eventually, the bladder has gotten as big and as strong as it gets, and sometimes we're unable to empty our bladder. Usually, though, there's in-between times, and those in-between times are as the prostate's getting bigger and before we are unable to get into a scenario where we're unable to pee. And that's where this bladder is strong, but it's not necessarily acting appropriately. And so we may get some urgency with urination where we're having to run to the restroom, or we're maybe even leaking on the way to the restroom. Or we have some frequency of urination where we have to go go every hour during the day and during the night. And so these things that we do during the day can really affect our kind of bladder habits and our bladder health, and then can lead into nighttime symptoms with regards to that. And so when I'm seeing patients, I like to rule out the nocturia as a result of the swelling, the CPAP or the obstructive sleep apnea, and then the fluid intake. And then once we've done that, I can decide, hey, this is more likely a prostate problem or a bladder problem. And oftentimes it's kind of a combination of the both.
So if you've decided that it's a prostate issue, what might you do, Dan?
There are medications that you can use to help shrink down from the standpoint of the prostate. Those are options. Have a combination of 2 different ones as far as with it, but like I said, that's probably the mainstay first, is you're helping to shrink down the size of the prostate. And for that too, you can start having some improvement, or at least know if you're heading in the right direction within 2 to 4 weeks as far as with it from that part already. And if I try some of those conservative things first that way, or try those medications if the other things didn't work and it's still not helping, okay, same thing. Then you get to see them too. And again, this is assuming all the time that PSA was normal too.
Right. And so let's say we've done, there's a lot of times medication helps. Sometimes we're on a couple different meds and it's getting worse, or it's not doing enough, and sometimes there's a surgical option. And just in minute overview, what is a TURP and how does that help?
Yeah, so what a TURP is, the idea of all prostate procedures is prostate making things like a coffee straw. I want to make things like a regular straw, where there's good flow through things. And so what a TURP is we put a camera, goes in through the end of the penis, and the camera goes into the bladder, goes through the prostate. You can imagine that prostate's kind of like a circle. So we take a look around the bladder, make sure everything looks okay, and then slowly using electrocautery, we kind of shave off that inside of the prostate. And we slowly make that coffee straw a regular straw. And so we slowly shave those pieces of prostate out, we toss them into the bladder, and then kind of get things as good as we can get. Usually I tell folks I can get somewhere in between 50 and 60% of their prostate volume out if I'm doing kind of a maximal TURP on them. And then afterwards, suck out all those prostate chips so they aren't sitting in the bladder anymore. And then usually we keep them overnight for a day, and then able to get the catheter out the next day and send them home. The thing I tell patients after any prostate procedure though is, hey, your bladder is still gonna think that it has to push through a coffee straw. And so that bladder is gonna be irritable, you're gonna have urgency, you might have some leakage or some incontinence associated with things. Give it 6 weeks, give it 3 months, and then you can come and yell at me if things aren't better. That being said, hey, a lot of patients come in 6 weeks and they say, the first 2 weeks you told me the right thing. I was not very happy with you, but 6 weeks comes around and they're usually pretty darn happy because that channel's nice and open, they've got a better stream, they're emptying their bladder better, and hopefully they're happier from a lifestyle standpoint.
Absolutely. It's a transurethral resection of the prostate, what a TURP is, or the Roto-Rooter procedure. But it is amazing how many times that can be helpful for men. And then they can urinate more freely, they don't have to get up at night as often, they empty their bladder more completely, and then they don't need to be on medications anymore, some of them perhaps. And yeah, that's not for everyone. You don't want to jump into surgery unless you need it.
Right.
But it's an option.
Truly, that's where the medications come first, and then if they're not helping, then you decide what you need to be more aggressive with.
Absolutely. Well, Prairie Doc spoke with Jim Eggen, a Brookings resident who was diagnosed with prostate cancer in 2010, as he shared what his journey has been like and the continued steps he has made to recovery.
It's very unusual from a standpoint of cancer patients, because my PSA, which is a value, if it's over 4, that's kind of a sign you're starting to see trouble. And mine, I don't know if it in my life was ever below that.
Eggen says his prostate-specific antigen, also known as PSA, continued to climb. When it hit a score of 17, he decided to get his first biopsy. Fortunately,
it was very, very low grade of cancer. It was like, they do like 12 samples, and it was, on those 12, only 2 of those samples had hits, and it only had 5% cancer cells, and it was very low grade or regressive cancer, so all of that was good.
From there, he began watchful waiting.
So I just talking a lot with the doctors, and I said, well, let's just see what's going to happen.
Egan says his diagnosis caused him to reflect during his journey.
I guess I feel that when you look around at a number of people at my age, you don't look at the obituary column, but you notice there's a lot of people that, from infants to a lot younger than me, so how could you feel bad?
He also added that a person's attitude plays an important role.
I think my story may be interesting because I think you'll find very few people, I don't know what the highest, but I know I asked Dr. Gillette, and people have had PSAs in the hundreds. So I'm not a record setter, but typically that number 4 is kind of the milestone. After that, you maybe want to go in. I guess I would say trust your doctors, first of all. I feel I have some great ones.
Egan is still monitoring his prostate health and consults with his doctor and is feeling better than when initially diagnosed.
Feel good. I go to Canada fishing every year for a week and feeling great.
Well, that leads into a question from a caller. When should I start being screened for prostate cancer, Dan? What do you recommend?
Typically around age 50. Some of that I will end up using some discretion if there's a family history of prostate cancer. I have one family where grandpa had it, dad had it, and now the sons are worried about this. Okay, I may start already at 40, every other year. Okay, 45, decide if we're every year already at that point, but like I said, they have a higher potential as far as with it, but otherwise 50. And then every year, and if you go by the recommendations as far as with it is up to 75. Now, I have a lot of patients that still want to have a PSA check beyond that. Fine. Okay, we start getting into our 80s and they still want to be getting it, and the question I have for them first is, number one, there's no problem getting it, but the bigger question is, if something came up with it, would you do anything about it? Okay, and then that's the decision to decide, okay, if you're willing to do something with it, then it's worth checking. And that's kind of what I will go by.
Yeah, and a patient may in that situation feel, I'd want to do something about it. But let's say an 85-year-old comes to you and there's concern for prostate cancer. What's your discussion with them?
Yeah, first of all, we kind of take a look at, for better lack of a term, the flavor of prostate cancer. There's kind of varying levels of prostate cancer. If you came and saw us for what's called Gleason 3+3 cancer 25 years ago, we would have taken your prostate out, or we would have put in radiation seeds. Now if you come in and you have that, oftentimes, and the preferred treatment strategy from the American Urologic Association is to do what's called active surveillance on these folks. And so that doesn't mean sending them out and saying, hey, you got prostate cancer, never see me again. This is, hey, we're going to check PSAs about every 6 months, get a good trend of these. Then we're going to repeat biopsies usually around year 1, year 3, and year 5 after diagnosis. The reason we do this is when we biopsy the prostate, we're taking needle cores of the prostate. We're not taking the entire prostate out. And so just like when you're shooting an arrow, you can hit a bullseye and you can hit something on the outside. Same thing here where, hey, I may not be hitting the most aggressive part of the prostate cancer when I'm biopsying it. And so if we have a lower grade prostate cancer and we're doing that watchful waiting, I want to keep biopsying in the chance that, hey, I'm probably going to hit something more aggressive if it's there at some point.
So, but if there's cancer, why aren't they recommending aggressive, take it out, have surgery right away anymore?
Yeah, and that's often because there was a study that came out of England, the PROTECT trial, and they looked at active surveillance. They looked at radiation therapy and surgery, with radiation and therapy, surgery being kind of the mainstays of treatment for a long time for prostate cancer. And that trial showed that in general, there was maybe about a 2% increased risk of prostate cancer-specific mortality or dying from prostate cancer associated with active surveillance versus the other two treatment strategies, and then a 10% increased risk of progression. And hey, not that we need to practice population medicine for everybody, but especially for that 85-year-old, the 2% increase in 15 years of prostate-specific mortality, at 100 if they die from it.
Especially when we weigh it against possible complications from the surgery, right?
Because I've had an 86-year-old with prostate cancer and elected to have surgery, and had a stroke during the procedure. Okay, how did we help him?
Yeah.
That's the debate. Okay, we're trying to help, not make something worse as far as with it. So no question, the younger you are, the more aggressive you should get. Okay, the older you are, okay, you have other decisions to talk about and decide other treatment options and maintenance and everything else as far as with it from there.
Let alone the incontinence and erectile dysfunction and leakage, and all other issues that can happen from surgery.
Right.
So I guess, that leads into here's a caller asks, I am 68 and dealing with lower libido. What can be done for this? I guess I don't mean to go out of prostate cancer discussion, but when you have prostate cancer and you have treatment, there's going to be complications. And there's the incontinence and the libido problems and erectile dysfunction. How do you talk to the patients to prepare them for this, for a treatment?
So when I'm talking about things like erectile dysfunction, I think erectile dysfunction is really hard to counsel patients on in terms of prostate cancer. That same study I was talking about, they looked at erectile function rates at 15 years for patients diagnosed with prostate cancer, and they found that all erectile function was about equal from the surgery group, the radiation group, and the active surveillance group. That's just to say that erections get worse over time. And so when we're talking about things, I want to obviously take a special interest in them, and I want to learn, are they still sexually active? Is this still a concern to them? I've got people who come in and say, I've got cancer, just get the cancer out. And then I've got other people that are saying, hey, if you can spare a nerve to keep those erections going, let's do it. And so I want to be, kind of cognizant of where they're at. And then I want to make sure that they know kind of, hey, this is what to expect with regards to my treatments, whether it be surgery, radiation, or otherwise. When we're talking about incontinence, that's a difficult question as well. But it's a little bit easier question because, hey, after this procedure, we've kind of taken out the prostate, we've reconnected the bladder to the urethra, and then we leave a catheter in for about 10 to 14 days afterwards. As soon as that catheter comes out, 100% of patients are going to be incontinent of urine. 100% of them. And patients, as soon as I say that, start to get a little antsy, and rightfully so. No one wants to be leaking urine all the time. That being said, I tell them, hey, that first 2 months, it's going to be a little rough. You're going to be using Depends. You're going to leak a lot. Starting at about 2 months to about 9 months, you're going to see leaps and bounds. You're going to be going to the bathroom. You're going to notice that your urination stream is probably a lot better than it was with your prostate in place. You're going to empty your bladder better. Are you going to leak when you cough and sneeze? Yeah, but hey, things are going to be tolerable. You may be using some pads, but you should be getting improved through that time. Our studies show that about 85% of our folks are dry by about 1 year after surgery. And so that's what I quote patients as I say, hey, if you're a part of that 85%, that's perfect. You're dry and we're good from that standpoint. If you're a part of the 15%, we have some options for you. And there's some things that we can do to help that, whether it be through medications or surgery. And we can talk about those once we get there. But hey, let's get through the first 12 months first and just know the first months are going to be a little tougher, but it's going to get better and better from an incontinence standpoint as we get further out.
So I think the bottom line is to remember that there's steps with this. We're going to watch those PSAs, going to see where the trend is. We may do biopsies, and we can see, does this look like an aggressive cancer that we really want to be aggressive with, or a slow-growing cancer that we can maybe just kind of watch, and so many factors involved with that decision. But
and not to interrupt you, but I mean, geez, hey, there's a lot of arguments to be saying, hey, you know what? If we can put patients on active surveillance and that 3-year biopsy comes back and says, hey, it's a little more aggressive now, but they haven't spread or anything like that, I've saved that guy 3 years of possibly good erections. I've saved him 3 years of possibly having leakage all the time if he's a part of that 15%. I'm pretty aggressive about active surveillance as a treatment strategy, even for younger folks. If that cancer is not very aggressive, I'm going to sit and watch it because, hey, that 55-year-old, if he can have 5 more years of erections, even if we do eventually transition from active surveillance to a more definitive treatment strategy for him, I really think that's an improved quality of life for 5 years for that patient.
Because there's a lot of prostate cancers that if we leave it alone, it might leave us alone.
Exactly.
But we all know other situations where it was bad too. So it's just, we don't want to ignore it.
Right.
Going back to the caller with the 68-year-old dealing with lower libido, switching gears a little bit, what would you do for that person, Dan?
There are a lot of variables involved with that. What medications are they on, if any? Do they take any supplements of anything? Have they had issues with depression? Have they had their thyroid checked? Diabetes? Anything else as far as with it? Because you're still looking for some underlying cause. Okay, so if you've ruled out anything else more major in regards to that, depression can still be a factor as far as the libido. Okay, so antidepressant may be something of benefit as far as with it from there. People will come in and will ask all the time on things like the Viagra and that. Okay, that's not going to change anything as far as your libido or your mood. Okay, so you have to make sure that what you're trying to come up with, you're trying to correct the right diagnosis or problem as far as with it. So this is where I say, okay, this is not the time to hold back on saying anything, or that you're embarrassed to bring anything up. I bet I deal with it 5 times a day. Okay, if we don't know about it, we can't do anything to help with it. So this is the time to be honest. It's between you and me at that point. Nothing leaves the room. What's going on? Sometimes you have to push a little bit harder on things as far as with it from there and say, honestly, help me out here. Something else is going on. What am I missing here? So,
along those lines, there's a question saying, I'm embarrassed to call my PCP about my ED. Can't they just call in a prescription?
Okay, well, the same thing. The medications, all medications, there's no such thing as one that doesn't have a side effect. Everything has something. Okay, so if you're gonna just prescribe medications and you never talked about the risk or complications with it or decide if it's safe for them to be on, you're not being practical. Okay, we need to know what's going on. Make sure, okay, is this drug safe for you to be on? What other causes may be, because may not even need those drugs as far as with it. But you need to know they are not, like I say, without complication or risk of anything else with it, and we want to make sure they're going to be safe to use.
And hopefully they're comfortable talking to us about something. And if there's some reason why they're not going to be comfortable, I hope they talk to us about that too.
Right.
And there's the fact that we talk about these things all the time.
Right.
So it's not, we're not going to remember.
Right.
We're not going to think about that when we see it at the grocery store.
Right.
It's in one ear, out the other.
Right. And I especially emphasize to them, heart disease. If you have some underlying heart disease already and you're on these medications, you can increase your risk with anything of that. So if you have anything of chest pains and you are taking these medications, you need to go to the emergency room and you have to tell them you are on these drugs. Why? Yeah. Nitroglycerin is one of the first things that we would end up using in the treatment of somebody with a heart attack. And nitroglycerin and these meds do not mix. Your blood pressure can bottom out with it. We have to know you're taking it. That is not the time to, I don't want to admit to anything as far as with it. I'm too embarrassed. No, your life could depend on it.
Yeah, good point. The Surgeon General recently updated its recommendations about the link between alcohol consumption and the increased risk for 7 different types of cancer. Prairie Doc spoke with Jason Sampirini, an assistant professor for the Master of Public Health program at Des Moines University, and Dr. Jeremy Byers, a family medicine doctor at Sanford Health, about this new warning and its impact.
The most recent key findings are that alcohol is a leading preventable factor for multiple different cancers. It's estimated that it is the 3rd leading cause of preventable cancers behind smoking and obesity.
Sampirini says a statistic cited in the report indicates that 72% of Americans reported drinking 1 or more alcoholic drinks each week.
So almost 3 out of 4 Americans drink on a regular basis or report drinking on a regular basis. So it's very common. Second point is that even though alcohol drinking is common, the knowledge that there's a risk association between alcohol and cancer is not well known.
Interestingly, as we think about this, we can think about it as we drink alcohol, it seems to affect those tissues maybe that it touches more. So mouth cancer, throat cancer, the voice box, which it doesn't really touch, it doesn't pass through the voice box, but it's one of them. The esophagus, the liver, which again, it doesn't touch, but it is really metabolized by liver largely. The colon and rectum, and then for women, the breast. Those would be the 7 kind of main cancers that they have found a clear association with increased risk.
Both stated men and women are susceptible, but women have an increased risk.
I mean, obviously, consuming less would be one, but then monitoring your other risk factors. You know, try not to smoke. Monitor your weight. Obesity is another risk factor, so that would be one thing. Making sure that you're eating well, so eating a diet that's maybe more anti-inflammatory, if you will, which typically involves vegetables and fruit, and limiting sugar, limiting processed foods, or processed meat especially is a big one.
I think, again, showing that there's an association between drinking alcohol and cancer risk, I think that's going to be probably informing future education programs. It's probably already happening as a result of this program. What I also expect, though, is maybe a little bit more quantifiable evidence showing the change in risk for specific subgroups of populations, focusing on harm reduction in specific groups who maybe have a higher burden of harm from alcohol, not just cancer, but alcohol abuse, driving under the influence.
So, it's a good reminder of just one of the reasons why you maybe think twice about having another drink.
Right.
We've got a lot of questions here, and one person from email asked, how can I tell if my testosterone levels are low, and what are the treatments?
Yeah. So when we're talking about low testosterone, first thing that we should think about is we want to think about the symptoms of low testosterone. And so the symptoms that we usually associate with low testosterone when we're thinking kind of colloquially is we think erectile dysfunction. Actually, very minimal amount of erectile dysfunction is related to actual testosterone problem. Oftentimes it's related to a vascular problem. Our vessels down in the penis are actually a lot smaller than even the vessels in the heart, and erectile dysfunction can kind of be that canary in the coal mine for heart disease. And so letting your doctors know about your erectile dysfunction is important from that standpoint. But erectile dysfunction can sometimes be related to a lower testosterone. So can lower libido, so can fatigue. And those are kind of the main things that I talk about with my patients. And so once you've started to notice those symptoms, then the first step is to get your testosterone checked. Usually I recommend we get our testosterone checked with a primary care provider first. We always recommend 8 a.m. checks when we're talking about testosterone. Testosterone fluctuates up and down throughout the day, and by checking at 8 o'clock, we have kind of a standardized way that we look at things. And from there, we can kind of decide, hey, is the testosterone low? Is it normal? Or is it high maybe sometimes? And we can go from there. If the testosterone's low, then we can start to talk about supplementation. Usually before we do supplementation, we'll consider whether or not maybe we need to run any other labs, look at any other hormones or anything like that. Oftentimes there's nothing else that's out of whack and it's just testosterone, and so we're able to focus on that. But sometimes we find other things, and supplementing with testosterone isn't the best idea. But there's a couple questions we'll ask as well. We'll ask, are they looking to still stay fertile? Some people don't know, but testosterone supplementation will cause sperm counts to decrease pretty significantly, and we can end up in a scenario where we inadvertently cause ourselves to become infertile as a result of starting testosterone supplementation. We talk to them about their lifestyle, and then we see how we can kind of fit in there. There's probably about, we'll say, 5 main routes that we can give testosterone. We can give it through things like creams. We can do, some pellets underneath the skin. Most commonly, we start patients on injection therapy. And so we'll start with an injection every other week, and we'll kind of be monitoring their levels, see kind of what that causes in results of their testosterone levels. But the main thing is not necessarily the testosterone levels when we get there. It's how patients feel. And so whatever the patient came in with, whether it be fatigue, whether it be lower libido, hey, if that testosterone's low, I don't want to increase it just to increase it and get it in the normal level. I want to increase it to make that patient feel better. And so we titrate to effect based on that. And hey, we'll check the numbers and kind of see where they're at. And so, hey, for future use, if we need to kind of manipulate things or change routes or anything like that, we can always try and aim for a certain goal where we know, hey, the patient had good effect at this, but that's kind of my role in testosterone testosterone therapy is, hey, let's figure out it's there. Let's talk about getting patients on a treatment, and then let's see how we can kind of adapt that treatment to that patient's life and getting that patient the benefits they want from it.
And of course, low energy, low libido, erectile dysfunction, all these things can be caused from a variety of other reasons. And then we also have to consider the risks with testosterone treatment. Dan, what are some of those risks?
Well, I'll even use as an example, because I had a patient in their 60s that ended up getting on testosterone replacement, and his cholesterol went through the roof. Okay, so now you have an increased risk of heart disease because of that. His PSA test for prostate cancer jumped up. We had mentioned before 4 is kind of the threshold. Well, now it was 14. Okay, what do we do with this? Was it because of the testosterone, or does he have something else going on as far as with it? Okay, every decade as we get older, that testosterone level is going to diminish. It's supposed to diminish. Okay, how much is that having that impact as far as their overall well-being? It's completely different from a 30-year-old to somebody in their upper 60s. That's where I'll say too, the art of medicine kind of comes into play, because you have to discuss, okay, well, what else is going on? Because a lot of those same symptoms can come just because we're 60 or over. And I can say that because I am. Okay, so part of that, as far as with it, you have to take all of that into account. If we're going to do a treatment, it needs to be safe. Now, for me, I've had it set where, okay, I'll evaluate and check and do anything with it, and if we come to the decision between us talking, they need to be on something with it, I send them to you or the endocrinologist. There are so many different ways of getting testosterone replacement as far as with it, and I am not about to be an expert on anything with that. So once they see somebody else of that, either urology or, like I said, endocrine, and they get them on a replacement and they're doing well, fine, I'll take back over again and I'll help monitor and maintain. But starting it, no, there are too many variables in it and too many other risks that I can't keep track of everything as far as with it as well. And so I want somebody that has more expertise on that part of it involved with it.
There's so many commercials now. Is this a fountain of youth?
I don't know if I would call it the fountain of youth. I would say that it can definitely make you feel better, but I wouldn't say it makes everybody feel better. I would say the people it makes feel better are the people that have low testosterone. And so, that's one big thing is testosterone is not something that, hey, if we added it a little more to every guy, would every guy feel a little bit better? No, that's not the case. It's more the case where if you're low and we replace it, we can get you feeling how you're supposed to feel. But not necessarily everybody can be improved by it. And so I think that's one big thing. And then the other big thing to kind of jump off what you were saying is monitoring afterwards. Hey, monitoring afterwards, it's almost just as important as starting it. And so we need to be keeping a close eye on patients' blood counts. And you say, why do I need to care about the blood counts? Hey, this can really concentrate your blood, actually. It can cause you to produce a lot more red blood cells, can make that blood thicker, can put you at risk of stroke, heart attack, things like that, blood clots. I mean, these are things that can happen as a result of that. And so testosterone therapy isn't something we just put someone on and then we say, hey, we'll see you in 2 years, we'll just keep prescribing it to you. We need someone who's qualified to watch you and keep a close eye on you while that's going on, whether it be a urologist, an endocrinologist, or a family practice doctor.
Right. And like I said before, there's no such thing as a drug or treatment of it that has no side effects. Everything has something. So, and you have to know what you're watching for and looking for.
Consider the risk of heart disease, strokes, heart attacks, prostate cancer, mood,
right,
aggression,
right,
changes, acne.
Yep.
What about
all of it?
Yeah.
Gynecomastia sometimes.
Yeah.
Peripheral conversion.
Yeah.
Yeah. So everything has consequences. Let's try to cover a few things here. Is it normal? This caller asks, is it normal to feel something in my testicles or scrotum? What would you say to that?
I'd say it's normal to feel two things in there, two testicles.
Yes.
That being said, if we're feeling something else, that's something to let us know about. The big thing that we talk about with as urologists is we moved away from the monthly self-checks for younger men with regards to things. What we found is the people that develop prostate cancer figure it out. Hey, they've got a rock hard testicle that's sitting down there. what we found when we asked everybody to do a self-exam every month is we found everybody finding this really small cyst in their epididymis, or we found, or some part of the testicle, or we found, hey, we found some small abnormality that I could feel around for an hour and I couldn't find it. And so, the biggest thing is, kind of saying, hey, is this normal? And if you have any questions, asking someone about it. Not being shy about it, not saying, oh, I'll put it off. And if you think something's abnormal and you notice something, then let's get it evaluated. But when we're talking about testicular cancer, we're talking about the actual testicle feeling like a rock, kind of with regards to things.
Dan, this person from email says, it takes me a long time to pee and takes a while to start. Should I be worried? What would you say?
Well, there's no question it's a nuisance, okay, but part of it, that's all in line with what we call the BPH and the prostate getting bigger.
Prostate, yeah.
Those exactly are the type of symptoms that you're going to have as far as with it. And again, what we talked about before as far as different evaluations and their treatment options as far as with it, because it gets old after a while. And there are things that can be done to end up helping with it. So it's not, I'm going to say normal or abnormal. It's not unusual. And that's what we'll end up having as far as with it.
Yeah. This person says, I'm going to have a vasectomy next month. Does this decrease my testosterone levels?
This does not decrease your testosterone levels. So vasectomy is a procedure where we cut the vas deferens on both sides, and that what that does is that stops the ability for sperm to go from the testicle up towards the rest of the body. But actually testosterone, although it's kind of made in concert sometimes with sperm, they are not necessarily directly related. And so there's a different hormone pathway through which testosterone's made, and that different hormone pathway is unaffected by a vasectomy or me cutting out a segment of that vas deferens.
Going back to what we were just talking about, prostate surgery removal, this person asks how long it takes to have an erection again. You covered that a little bit, but a brief answer, what would you say?
Yeah, erectile status improves for 2 years after prostate surgery in terms of getting your prostate removed. Other procedures that kind of manipulate the prostate, not completely remove it, take less time, but we talk about a 2-year kind of improvement time frame with regards to taking out the prostate.
Heart disease is a very important thing for men too. And this question has more to do with heart disease. Dan, I'm worried because several of my family members have heart disease. What should I be looking for and what should I talk to my doctor about?
Again, age has a factor as far as with it, what other medications are on, but have they gotten screening tests, cholesterol? What is the family history? Who in their family has had issues as far as with this before. They have those heart screening tests that you can get, the CAT scan, cardiac scores as far as with it. They're beneficial as being used as a tool to help in the investigation of what you're trying to decide if there's an issue or a problem with it. But I could talk about symptoms and I could line up 100 of you and you're all going to tell me something different. Okay, so chest pains, okay, if you're having that, yes, that is the big one, but you can still have other symptoms of heart disease and not be anything related to chest pain. So that's where, like I said, we need to see and evaluate and go through those things to decide, okay, is there anything going on or not?
And of course, watch the blood pressure.
Absolutely.
Diet and exercise.
All part of the evaluation. Prevention is still going to be the key. Okay, diet and exercise, when I tell everybody I have 2 things that can end up helping with it, and then when I say diet and exercise, I get all the eye rolls and everything else as far as with it, but there's still nothing better.
Yeah. This caller asks, what medications can affect erectile dysfunction?
Yeah, so there's actually a lot of medications that can affect erectile function. And so it's medications like the SSRIs or antidepressants that we use. It's medications like ACE inhibitors or some blood pressure medications. These can affect it. It's medications like anti-seizure medications that can sometimes have an effect on it. But mainly when we're talking about medications that affect it, a lot of people talk about the SSRIs or the antidepressants as being some of the main offenders with regards to that.
And probably, just to put it out there, I hope no one just stops some of those medications that you listed.
Correct.
Because of the possible risk of erectile dysfunction without talking to the doctor.
And hopefully they were talked about this before they got started on it, because it is one of the biggest side effects as far as with it. So, because I even had a patient come back afterwards and said, okay, now I have erectile dysfunction. If I wasn't depressed before, I certainly am now. Okay, so this is part of life. Okay, this is all a factor as far as with it on there. And yes, you have to go through those ramifications and side effects of those medications beforehand so they have an idea what could be. Can you go through all of them? No. You're going through the majority of things that have the highest potential as far as with it.
And there are some other antidepressant options.
Correct.
And it's hard to be romantically involved if you're depressed.
Right.
So, I mean, we still want to get the depression taken
Correct.
care of first.
Absolutely.
But those are some things to
Yes.
consider, absolutely. Just in the last couple minutes here, oh boy, there's all sorts of good stuff here. I underwent proton beam radiation treatment for prostate cancer 5 years ago with an extremely low PSA. What are my chances of recurrence of prostate cancer?
Now we're getting really into the weeds. So focal therapy for prostate cancer is something that's a little bit still in the works, in the sense that we're still waiting a little bit to see some of the longer term studies in terms of treatment effects and kind of the staying power of some of these therapies. What he's talking about is he's talking about not treating the whole prostate like we would with radiation or with surgical removal of the prostate for prostate cancer. He's talking about treatment of part of the prostate and then leaving the other part of the prostate there, with hopes that it can lead to decreased side effects with regards to that. As far as having a low PSA afterwards, that's the hope. It does get a little bit more difficult to traffic or to kind of follow these patients afterwards. After we take out a prostate, PSA goes down to 0. If I ever see any more PSA in their body, I know the prostate cancer might be back. And so I know to look. With patients that have the prostate treated partially, but they have some healthy prostate tissue, let's say on the other half of the prostate, that prostate is going to continue to grow. The PSA is going to continue to rise. And I'm sometimes going to be able to, have trouble seeing whether or not there's concern for prostate cancer recurrence, or, hey, this is just the normal increase in PSA with time. And the best way to do that is MRI and biopsy. And so usually patients that are undergoing proton therapy should go on a surveillance strategy afterwards, where we monitor PSA, we talk about scheduled biopsies and MRIs in order to make sure that, hey, we don't see any evidence of prostate cancer. And that's a discussion between you and the doctor that did that.
We had some great discussions about enlarged prostates and prostate cancer and men's health in general. And in 10 seconds, your best advice for men as they get older, what would you recommend?
Stay active, use it or lose it, and make sure you have your yearly evaluations.
Sounds good. Thank you, Dan. Our winner is Mark. A book will be sent to you shortly. We'll be back after this. Is perfect.
Your local newspaper or read online the Prairie Doc Perspective, a weekly health and medical column. Head to prairiedoc.org to access all archived columns today.
Thank you to our guests, Dr. Edman and Dr. Reiffenberger, for volunteering their time to help us learn more about issues surrounding men's health. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Let's be clear, the importance of eye health cannot be understated. By taking care of your eyes, you will reduce the odds of blindness and vision loss. Seeing through a clean lens, the importance of good eye health. Next time, On Call with the Prairie Doc.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,